Next, we are going to hear from Dr. Meaghan Doherty. She is a graduate of the University of Massachusetts Medical School. She went there to complete her pediatric residency at Hasbro Children's Hospital, affiliated with Brown University. Following residency, she moved to Pittsburgh for advanced training in pediatric cardiology at Children's Hospital of Pittsburgh, which has a robust heart failure and cardiomyopathy program. Additional clinical focuses during training included fetal cardiac imaging and management of complex congenital heart disease. Since returning to UMass, she has become the primary cardiologist for the Duchenne Muscular Dystrophy Clinic and has greatly enjoyed getting to know most of the families over the years, both in person and in many cases recently via telehealth. She is looking forward to increasing involvement in the DMD clinical trials by interpreting cardiac imaging for these participants. Additional research pursuits involve assessment of cardiomyopathy in patients who have had COVID-19 infection, as well as ongoing quality assessment of fetal patients with cardiomyopathy and complex congenital heart disease. So thank you so much for being with us, Dr. Doherty. I will go ahead and turn it over to you.
Great, thank you so much. I'm gonna share my screen. Okay, great. So thank you for having me. I'm very excited to participate in this symposium. So I'm going to go a little bit from the beginning, talking about the heart itself and the heart cells, and then we'll kind of walk through some of the treatment options for Duchenne's muscular dystrophy and sort of where we're going from here. So I think, most of you know that Duchenne's is a progressive disease of the muscles, which affects the skeletal muscles as well as the heart, leading to progressive weakness over time, which from a cardiac standpoint results in cardiac dysfunction and potentially symptoms of heart failure. The heart is a pump. The pump is made of the muscle tissues that are a particular type, unique to the heart, but they are a striated muscle, which is similar to what you see in skeletal muscles. And the way the heart pumps is the cells are activated by an electrical current. This affects the proteins within the cells of the heart to pull and overlap. And when all of the cells do this at a relatively synchronous fashion, it results in a gross pumping of blood out of the heart. There we go. So this is a look at what the heart muscle tissue looks like under the microscope. And you can kind of see the stripes that I was speaking of. It's something that you can visually see through the microscope. And this top image here is actually one single cardiac muscle cell. And, oh, I'm sorry, actually this is an example of a skeletal muscle cell, but it's similar. Within the cell itself, you have these things here that are all lined up called myofibrils that are then broken down. If you look even smaller, you can see the different sort of zones of the filament. And within the cells, you have these different kinds of proteins. So you have these are called the thin filaments, and then the darker red here is the thick filaments. And basically, when the muscle tissue contracts, you have overlapping of thick and thin, and it pulls on each other and pulls on the outside of the cell so that it all contracts together. And the role of dystrophin, why it's so important, is dystrophin is like an anchor that connects these filaments to the outside of the cell, so that when there's contracting or overlap of those filaments, this results in pulling on the outside of the cell, and when all of the cells pull on each other, you get that coordinated movement. So when there is a problem with the structure of the dystrophin protein, you can have the overlapping of the thick and thin filaments, but unfortunately that effort is not going to result in the coordinated contraction of the cells. So this is a very complicated slide that I'm not going to get into in too much detail, but basically it starts at the top from the gene abnormality and abnormal protein, and how ultimately there's different kind of cascades that occur with injury and inflammation. And what that means is that there's different places along the pathway that we can target for therapies. And what we have now is kind of a variety of different medication options that we commonly use to help offset the worsening of heart function over time. So I'm going to back up and talk a little bit about cardiac monitoring. So kind of the key information that we get right now with regards to how a patient is doing and how their heart is doing is very much based on the imaging, which is frequently done through echocardiography, which is ultrasound, or with cardiac MRI techniques. Often the first sign of any kind of change or abnormality with the heart is first identified through imaging. Most patients do not become symptomatic well until after we sort of identified some changes that we see with our imaging. And so that's why routine imaging is really important even when patients feel well. It's also unusual or unlikely that we were going to identify abnormalities on the cardiac exam. The first thing that we're going to see is often some dilation of the heart, which we see just by looking at it with these modalities. So we're looking at the size of the chambers of the heart, which we compare to each individual patient's body size, which is obviously important in pediatrics. We look at the function of the heart, and function means how well it's squeezing. And this is a number that is kind of important to keep in mind, is what we consider a normal function, or what we say is ejection fraction, is over 55%. Ejection fraction means the percent of blood that is getting pumped out of the heart. So, for example, if we just assume, to make it easy, that the heart fills up with 100 milliliters of blood, a normal amount of blood to be ejected when the heart squeezes would be 55 of those millimeters. You would never have the heart just completely empty after a contraction. There's always some blood left there. And so 55% to some people may sound worrisome or scary, but it's actually what is considered normal. Below 55 is abnormal. The third thing that we look for with our imaging is evidence of myocardial fibrosis or scarring. And that's something that we can only see with cardiac MRI. We cannot see this by echocardiogram, which is one of the limitations with that. So ventricular dilation is important, and when we do identify that even early on, we do tend to be proactive in optimizing our medication. And the reason for that is, if you look at this example using a skeletal muscle, you can imagine that if somebody was going to carry a heavy box, for example, they would naturally put their arm in the position of the middle hand, with the elbow at about 90 degrees, because that's the optimal length of the muscle where it's the strongest. If you tried to hold the same amount of weight with your arm either further extended or bent, it would be much more difficult. And the same thing applies to the heart. When you start to see stretch or dilation of the heart, it makes the heart work harder, and we try to offset that. So dysfunction of the heart happens when the ability of the heart to contract is out of it is less in proportion to how hard the heart has to work, meaning the afterload. That's the force that the heart is pumping against. And you can think of that as simply the blood pressure, just to make things a little bit easier. And if the heart is having more difficult more difficulty generating that contraction, if you lower the work that the heart needs to do, you can maintain better output from the heart. And that is what we try to target with our medication. When there's injury to the heart muscle itself, over time, the heart does, the muscle remodels. So remodeling is a process of where you see replacement. So you receive replacement of healthy muscle cells with scar, which obviously doesn't contract well. Another target from some of our therapies is try to act on the hormonal aspects and the signaling of this remodeling process to prevent further damage from occurring. When this damage does occur, which unfortunately at some point you will see some evidence of fibrosis in all patients with Duchenne's muscular dystrophy over time. This is something that we see with cardiac MRI, as I mentioned before. What the radiologist is looking at when they're assessing for fibrosis is they're looking for something called late gadolinium enhancement or delayed gadolinium enhancement, where about 10 minutes or so after giving an IV contrast injection, you see enhancement or brightening of the muscle cells when you look at it with the MRI, and that suggests that there is in fact some degree of scar formation. The fibrosis is not reversible, but we do have some ways of trying to slow it down, as I mentioned earlier. So therapies for cardiac dysfunction in the setting of muscular dystrophy is something that is really exploding, I think, in a very positive way. We, at this time, although we have a lot of information available to us, we still have a lot of questions, and there's certainly room for ongoing investigations. But there's sort of three classes of medication that we use when we are dealing with cardiomyopathy, or in some instances trying to prevent it. The first class of medication that we use is called, we call them ACE inhibitors, which we block this step in the pathway that prevents this chemical conversion. ACE inhibitors are known as enalapril or lisinopril, and are very, very commonly used in the setting of Duchenne's muscular dystrophy, as well as other indications as well. A lot of people are on it for high blood pressure or other forms of heart problems. But in the DMD population, we actually have very solid evidence that starting this medication prophylactically, meaning before any evidence of cardiac involvement, is protective in the long run, and that the patients with muscular dystrophy who are started on it by age 10 over time will do better with regards to their heart function compared with patients who are not started on it. So it's a very, very strong indication for us to prophylactically start patients on ACE inhibition, and it is something that we do standardly in our clinic. The evidence is shown in boys who are 10 years of older, and one of the frequent topics of conversation or questions that comes up is, well, if it's beneficial to start it at age 10, why not start it at age 5? And I think that's an area where ongoing research would be helpful. The next category of commonly used medications are the aldosterone antagonists. So aldosterone is a hormone that and is by blocking the effects of that hormone, we have a positive effect on that remodeling process that I was speaking of earlier. Some people call these medications like antifibrates, meaning they work against the development of fibrosis. But what the data shows in looking at the research studies in the Duchenne's population is that if patients are on an aldosterone antagonist and have evidence of myocardial fibrosis on MRI, that in the long run, these patients will do better to be on that medication. Um, we don't know if starting the medication prior to the evidence of fibrosis would be beneficial or not. So we standardly start all of our patients who have evidence of fibrosis for the first time. We make that recommendation to start this class of medication. The third common class of medications that we use are the beta blockers. This is another type of blood pressure medication that's also commonly used in cardiomyopathy or heart failure. And in the setting of Duchenne's, we have found that this medication is beneficial and slowed decline of cardiac function over time if there is evidence of dysfunction to begin with. So this class of medications generally gets started when we start to see worsening or decrease of that ejection fraction number that we spoke about earlier. So altogether, these medications work to reduce how hard the heart is working and prevent that remodeling process, which is something that happens at the cellular level. And I sort of just went through the indications for the different classes of medications that you can see here again. So ACE inhibitors are often used prophylactically, starting at least by age 10. Aldosterone antagonists work with evidence of fibrosis, and beta blockers are added when we see evidence of ventricular dysfunction. So this is sort of the main highlights of where we're at now with regards to our medical therapy. But of course, we want to be forward thinking and say, well, where do we go from here? It would be ideal to have more of a focus on prevention and delay the onset of the cardiomyopathy. As most of you are aware, there's very aggressive research efforts in this population, which is wonderful, and ongoing clinical trials. And I did, there's the question about the gene therapy trials and the effects on cardiomyopathy. And I would say that this seems very, very promising. And I think it will be hopefully the wave of the future for our patients. Another area of research is looking at what we call biomarkers. So other ways for identifying which patients are at risk for early development of cardiac dysfunction, and can we be more aggressive in certain subsets of the population who will respond the best. So those are other things that are being looked at. And I wanted to take just a few minutes to talk about the COVID-19 pandemic, which is, unfortunately continuing, and in some areas very, very active. There were some guidelines that were put out last year in April by a number of experts in the field about what to do should your child become sick or be diagnosed with COVID-19. The first thing, of course, is to contact your own child or family member's provider and get recommendations. And go from there. The next thing that I did want to talk about is vaccine considerations, because I do hear about this a lot from our patients. The vaccines are relatively new and people want to understand, are these safe or not? And particularly with regard to the recent reported incidences of myocarditis and pericarditis, which is an inflammatory process in the heart. Our patients with Duchenne's muscular dystrophy already have some inflammatory process of their heart, so I can understand why anyone, and particularly families with patients of Duchenne's muscular dystrophy, would not want that as well. So this is from the CDC website, and just looking at the number of people who have been vaccinated. So over 177 million people have received the COVID-19 vaccine in the US. And amongst those, there's been about 1,000 reports of vaccine-related cardiac inflammation. I've seen this, and I will say that from what I have heard and what I have seen, these cases are incredibly mild, and the patients have all done well. in one instance, the patient got one dose of an anti-inflammatory and the pain went away, and we monitored them on a heart monitor overnight and had no further issues. So I feel that that's very reassuring. The CDC does continue to recommend this vaccination for everybody 12 years of age or older, especially people who are at high risk. And that would include patients with Duchenne's muscular dystrophy. So getting vaccinated is the best way to protect yourself and your family. I can tell you that within our clinic, we have had the majority of patients who are eligible have been vaccinated, and overall are doing very, very well with this. We haven't had any definitive cases of myocarditis within our clinic. One patient did present due to some unusual symptoms that are unclear whether that's related or not. But I find that to be incredibly reassuring. So if you're uncertain or have any additional concerns about it, then I highly recommend talking with your medical team to make sure all of your questions have been answered. So at this time, I'd like to open it up to any questions that anyone may have.
Thank you, Dr. Doherty. So in our Q&A box, you might be able to read it. It's a question we have about a presentation, and I don't know if you know it or not, by Dr. Lee Sweeney, mentioned that gene therapy can cause dystrophin expression in the heart to go up, and contrary to the general expectations, this can cause detrimental effects because the mini microdystrophin cause the original utrophin expression in cardio muscles to go down. Are you familiar with this presentation, and do you have any update on that if you happen to know about that presentation?
I don't feel that I can adequately comment on that. I think that I'd kind of defer to what the experts who are involved in the trials are, yeah.
Okay, I just wanted to make sure. Yeah. And what is your view about losartan in place of ACE inhibitors?
Yeah, that comes up fairly frequently. So a common reason for transitioning from an ACE inhibitor to losartan, which acts similarly in the biochemical pathway. It's just a step further down in the cascade. So we, in the medical community, feel that the ultimate results is quite similar to being on an ACE inhibitor, but ACE inhibitors are older, have been around longer, and are less expensive, quite honestly. And so a lot of people, they're sort of the go-to first line. But common reasons why people may be changed to an angiotensin receptor blocker, such as losartan, would be a side effect such as the chronic cough that can happen with ACE inhibitors, not that uncommonly. Okay. I personally would not consider that any great loss or disappointment to change that class of medications, as we do feel that they're comparable. And sometimes we often, in patients, especially who are on multiple medications, may experience dizziness, as all three of these classes of medications are blood pressure lowering medication. Sometimes we try, in patients who were not able to increase our dose or to tolerate a reasonable dose, we might try switching from lisinopril to losartan, for example, to see if the side effect profile is better tolerated from that regard as well.
Interesting. Okay. All right. Thank you for answering that. Just to ask, you had talked about, and I wrote a note, routine cardiac imaging. When you say routine cardiac imaging, even if you're not having any symptoms, how often would you recommend someone get imaging done?
Yeah, that's a great question. And I do think that it varies from different centers. So generally in the younger patients less than age 10, the recommendations are to have cardiac imaging every 1 to 2 years.
Okay.
We err more on the side of the annual evaluation. I think 2 years is kind of a long time to go, and there are a fair number of patients where we do start to see Subtle changes such as dilation or sometimes some thinning of the wall of the muscle. Although the heart is squeezing fine, we like to, in those instances, be fairly proactive with starting. I usually start lisinopril when I see that, even
Okay.
in a patient who's 5 or 7 versus 10. So I like to have more opportunities catching those subtle findings more frequently. Once the patients have turned 10, that's generally when we start. Um, less than age 10, usually our screening is with echocardiograms,
Okay.
which is, it's generally tolerated a little bit better. Parents are with the patient who is awake, and we're just, using the ultrasound gel on the chest. A cardiac MRI is a very long procedure, and we often try to do breath holding and different techniques to optimize the imaging. And if we're looking for evidence of fibrosis, it also involves an IV. So it can be challenging in younger patients to have that type of an evaluation. So a rule of thumb is usually by about age 10, most patients can tolerate an MRI without sedation. That is certainly not universal, and we have a lot of patients who also have other factors such as behavior issues or autism, and may not be able to tolerate it, but a good majority of patients by age 10 can tolerate cardiac MRI. So that's usually when we start routinely getting that evaluation on an annual basis. And we often split the interval time with an echo around 6 months. So depending on how patients
Okay.
are doing, we may go up to every 6-month evaluation at that point.
Okay. All right. Thank you for explaining that. We have a question here. So we have Amy who is listening. She's a carrier of Becker and has 3 sons. I have recently been diagnosed with cardiomyopathy and wondering if we determine this is from Becker. If we determine it's from Becker, is it probable that they will also develop it? They are relatively young right now. My oldest with it is 13.
So not quite certain if the children have been tested. I think that or any unaffected children have been tested. Becker's tends to be a little bit more variable in the presentation. I think some people think of it as a more mild, what we call phenotype or expression of disease, although that isn't always the case with the heart. So just want to be cautious of becoming overly optimistic. But if she's identified as being a carrier, then screening for her children would be indicated, and to help determine what type of cardiac surveillance is needed.
Okay, thank you. I am not seeing anything else. I just want to check both of my boxes here so I'm not missing anybody. I don't see anything else, Dr. Doherty. Thank you so much for your time today.
Yeah, thanks for having me.